Good evening. Good evening, ladies and gentlemen. Dear students, so a warm welcome from us to host you here at the Universitas debate on the pharmaceutical sector, a force for good. So we are very happy to have such great attendance this evening. Now, this debate is part of the Universitas series of lessons and debates which focus on the third culture. And this was initiated at Ghent University by Professor Yves Tjoen and Kurt de Frank. So, indeed, during this Universitas series, students, professors, alumni, and other interested parties are involved in the conversation between scientific disciplines. Universitas facilitates interdisciplinary and transdisciplinary dialogue across the specialist boundaries of research groups, departments, and faculties. How do we bring diverse scientific disciplines closer together? And what can we, as researchers from different fields, learn from each other? So these questions form the basis of this kind of meetings that are organized at various locations at Ghent University and in the city of Ghent. The starting shot of Universitas was already given in October 2021. And the goal is to strive for more interaction and debate between academic programs. So indeed, we want to narrow the gap between alpha, beta, and gamma sciences. Now today we are very happy to present to you the initiative that was taken at the Faculty of Pharmaceutical Sciences. So indeed, a couple of months ago, a core group at our faculty started to co-create this event. And it's indeed my pleasure to thank the whole team who worked towards this evening. So we have my colleague, Professor Dieter de Vors. So today, he and myself, we will moderate this evening. So I'm Sarah de Zager, so we are both teaching at the Faculty of Pharmaceutical Sciences. My other colleagues, Professor Marthe de Bouvre, Professor Valérie van Hoorne, Professor Koen Boessery, Professor Stefaan de Smet, and Dr. Céline Meerpoel, they all work together towards this event. Now, this debate is also linked to the bachelor course, which is called Societal Impact of Drugs. And this is a course coordinated by Professor Valérie van Hoorne, and it's taught at the 3 bachelor years in pharmaceutical sciences. So this course focuses on drugs that change the world, on ethics and sociology, and also on professional development. So because indeed in our faculty we want that our students become critical thinkers who understand the societal impact that they will have in their future jobs. I'm also happy to welcome some students of the Ghent University broad elective course Global Minds, who are also present here this evening. Also, this is part of the Internationalization at Home initiative and also part of the university-wide developmental goals. So, and also as far as I know, this is the first debate that our faculty is organizing on this scale. So we are very proud that we have organized it today. Okay, this was the introduction. More important is our exceptional panel that we have here this evening. And they will start the debate on a very important and timely topic, which is to address some key questions on the global 21st century challenges in the pharmaceutical sector.
It's my pleasure to introduce the first of our panel members. We are quite honored with having such a high level of panel speakers who I think are globally active. Dr. Ajit Baron-Shetty is our first panel member. He has spent most of his career in pharmaceutical industry, not just in pharmaceutical industry, but really at the top of the pharmaceutical industry. He has served as chairman of Janssen Pharmaceutica, and he has also been a member of the operating committee of Johnson & Johnson. Dr. Ajit Baron-Shetty obtained his master and PhD degree from Trinity College, University of Cambridge, and an MBA from Carnegie Mellon University in the United States. He has spent a lot of his career in pharmaceutical industry, but not only in pharmaceutical industry. He now serves, for example, as the chairman of the Flemish Institute for Biotechnology, the VIB, as we say. He's a member of the Institute of the Tropical Medicines Institute. He's also chairman of Newton Biocapital, member of the board of Sudal. He's active in North America, Europe, and also in Asia. And so we're very happy to welcome you, Dr. Ajit Baron-Shetty. And maybe also important to mention is that you also are an honorary PhD of our university.
Thank you.
You're welcome. Then Dr. Dimitri Enekel. He's a very important member of the Artsen zonder Grenzen, Médecins Sans Frontières. He has spent the last of his 5 years, if I'm informed correctly, as a policy officer and representative to the EU. That's probably what we call a lobbyist.
Yes.
So he has a very important role there to play. He's also coordinating, or he has been coordinating the access to the COVID-19 vaccines. And he also holds a publication, and that's also an important topic of the night, on intellectual property law in the pharmaceutical or medicines sector. He's been active all around the world, Haiti, Afghanistan, Libya, South Sudan, and he holds a degree in history and additional master degree in international relations and conflict management. Welcome. Thank you for coming.
So then I'm also happy to introduce to you Professor Marleen Temmerman. So she's appointed at the Center of Excellence in Women and Child Health at the Aga Khan University in Nairobi, Kenya. Prior, she was the director in the Department of Reproductive Health and Research at the World Health Organization. She's also the founding director of the International Center of Reproductive Health at Ghent University. She's a professor emeritus from Ghent University. She's involved in many different scientific advisory committees at European and also in developing countries' clinical trial partnership. And she has been awarded an enormous number of awards, and I will just mention some of them. The highlights, like the Burning Spear, awarded by His Excellence President Kenyatta from Kenya in 2020. The U2 recognition as women leader by Bono during his 2017 Joshua Tree tour in Brussels. So, Marleen, welcome in this panel. And last but not least, we have Professor Koen Schoors. He's a professor at the Department of Economics at Ghent University. His academic interests are on many things related to economics, so banking and finance, law and economics, development economics, institutional economics, economics complexity, energy economics, political economy of Russia, and economic and financial crisis. He's publishing in many different international journals. He's a very active contributor to the public debate on economic and social policies. He has, for instance, served in various expert panels for the Belgian and the Flemish parliaments and under the auspices of the Prime Minister. So, welcome, all of you. So now I would like just to give you the floor to give a very short pitch. So we asked the panel members indeed to present themselves and to give some more personal insights in their career development by showing also who or what has inspired them during their lifetime. So, and I will therefore first give the floor to Professor Schoors.
Dank u wel. Het kunstwerk dat u ziet, dames en heren, is een kunstwerk van... in English? Okay. A piece of art you see, ladies and gentlemen, is a piece of art of a Belgian artist. His name is Rinus van de Velde. And usually he's working with charcoal, making big paintings. But this is actually in clay. I saw it accidentally in a museum. And what it is, it's a big table. It looks like a boardroom, and lots of people are talking, lots of paper, and they're doing things. And it inspired me because I had the feeling in my life there was too much of this. Too many meetings, too much talking, too much blah, 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 blah. And what I wanted to do after seeing this is try to be more active, be more activist, do more things myself directly. So not only trying to move things at board tables, but also trying to move things directly by trying to inspire people through teaching, through writing columns, through being active in debates. It doesn't mean this isn't important. I think it's very important, but it wasn't giving me any personal pleasure or enough personal satisfaction. So I wanted to do something more direct, and that is like the piece of art that inspires that. Which brings me to the next slide. This is one of the books I read. There's many books I could have taken, but that's one of the books that I think is really fascinating. It's a piece of work of Achimolu and Robinson, Why Nations Fail. And in this book, they basically have a very broad view of the world. You could discuss about it, but essentially they try to ask, why are some countries more successful, more healthy than others? And their answer is, it's not what we think. It's not investment and big things. It's something else. It's institutions. And the idea of institutions is, these are the rules of the game. There could be informal rules, social norms, trust, reciprocity, or formal rules. Is it democracy or not? How does the political economy work? Is it a corrupt country or not? Do we have proper property rights or not? And these are the things that matter for outcomes. Not the things we usually teach or believe. It's about the institutions. It's the rules of the game we make with one another. And I think this is very inspiring. And it has to become the way I see the world. If you can change institutions, an institution is not like the World Health Organization. It could be much more informal. And in the last slide about my personal inspiration, that's a statue. And it's actually in bronze. It's two figures. It's made by Tolle, a female artist. And it's two figures, and one is holding the other with a rope, like this. And but it means it could. The thing I like, first of all, it could mean many things. So everybody who sees it thinks of something else. But the way I think of it, so you could think of it as two persons, but I also see it as one person. It's one person. And so on the one hand, at the bottom, it's me, and you have to do all your work, and you have to make your publication, you have to do your teaching, get evaluations, and sit on boards of places, and do all these important things. But that's heavy. It weighs me down. And there's the other me, and that's the person that wants to play, that wants to be free, that wants to do things for himself, that wants to be creative. And in a way, what it means to me is I need both persons. If you only have the upper one, I would be gone, completely disorganized, doing all things without any results. But if I would only do the bottom one, I would get bogged down and not inspired and not creative, and I would become a slog. And so, and being both at the same time, trying to do things at the boardroom and work hard, but also be creative and be free, and sometimes say whatever, I'll do something else now, I'll go to party. These two things together work for me. So these are the three pieces of art for my inspiration, essentially.
Thank you very much for this inspiring introduction. So now I will give the floor to Professor Temmerman.
Thank you, and a very good evening to all of you. Happy to be here. Happy to be in Ghent, because I'm a student from Ghent University, and I had to smile before I go to my introduction. When you were talking, Sarah, about alpha, beta, gamma. And I looked at my colleague, Professor Jan de Maasnier, because in the old days, 20 years ago, we were struggling from the gamma to work together with the alpha. And we were always told when we came with the proposal, no, this is alpha, this is beta. So it was really discouraged. And I'm so happy to see now that we live in a time where kind of co-creation and working with other faculties and other scientists is encouraged. So good evening. We were asked to give, I thought, only one piece of art, but anyway, some. So I have only one, sorry. And I took it, and there are many that I had to choose from, but I took The Constant Gardener. It's a book written by a thriller by John le Carré. I hope that some of you know John le Carré. If not, please look it up and read some of the works of John le Carré. This one is actually about research and about pharmacology and about doing trials in developing countries. It's a story 20 years ago. It's a book, but there is also a film, a movie, and it's really worth, because it's still there a bit. So what happened? I live in Kenya, in Nairobi, and the movie and the book is about a trial that was done in the slums, Kibera slums in Nairobi, so I know that area very well. That's why I like it so much, and I read the book so many times, where a drug was tested by a company. So there were very few rules and regulations. Times have changed. But a trial could be done, and patients or participants were just paid to participate in the trial, and if something went wrong, one of them got sick or died, kind of ignored. It was not recorded in the books. It was, people had no rights. They could not claim anything. So it's maybe still happening in some countries, but I think globally a lot has changed, but it's really a good lesson. So that's why I really would recommend The Constant Gardener. Next. So then a bit about myself. I'm a medical doctor, a gynecologist. I did public health, tropical medicine, and I wanted to go and work globally. And the opportunity was there really created by a good friend and also an alumnus, a very famous Belgian, Professor Peter Piot, a microbiologist, who called me one day and said, well, you know, we need someone with kind of interest in reproductive health, maternal child health, because there is a strange new disease in '85, HIV/AIDS. We didn't know much about it at that time. And we have a group in Nairobi who is doing research, and we want you to lead a small project. We didn't have much money. Number one, the question was, can women be infected with HIV virus? Now, that's easy to address, right? But the question was there because AIDS was a really white man disease, gay man in the West, and we didn't know anything about Africa. And the second question was, can it have an impact on pregnancy, women and children, etc.? There was no medication, no drugs. We will surely address that later. So from then, my life started in '86 in Nairobi. I've been back and forth, but I'm still there, and I live there for the last 6 years again. Next. But doing research is one thing. So I used to work in a very busy maternity in the slums in Nairobi with about 100 deliveries a day. A lot of HIV, but also a lot of maternal mortality, shortage of everything. So of course, from research, you move to trying to do things, to change things, to raise funding, also to address women, children's health, because women and children are the rights of the women and children are more violated in the human rights sector. And the next. So then I think that's the last one. I moved also to, coming back from Kenya, joining the university again, I did my PhD here, created an international center for reproductive health that is still very, very active and leading a lot of work here in Ghent, but also in Kenya, in Mozambique, in many other countries. From there, I moved to WHO, the World Health Organization, to engage in areas, you won't be surprised, women and child health, rights, human rights, sexual violence, FGM, all the family planning. A lot of topics were led by the department where I was a director. And it was a unique opportunity to understand the global context and to work in a global health organization, actually, that really helped me a lot then to go back to Kenya and take a leadership role there. I think that's the last one. Thanks.
Thanks a lot. Dr. Ennikel.
Is mic on? Yeah. Yes. First, a small correction, I'm not a doctor. I studied history and international relations, so I can imagine that lots of you think why I'm on this panel, but I will come to that in a minute. After my studies, I did a few jobs in companies and organizations, and in 2010 I joined Doctors Without Borders, Médecins Sans Frontières, going to Haiti after the earthquake, for those who remember, so the images of Turkey ring quite close to me, or ring, you know, bring back some memories from spending time in Haiti in 2010. But then after that, I went to Afghanistan, and I think this was probably one of the most interesting experiences that I ever had in my life. It's an absolutely fascinating, beautiful country. Culturally very rich, which is a bit the opposite of what a lot of people may think from, you know, being based here or what we read in the news. But it's really the cross-section of different cultures. It's a geopolitical pressure point with India, Pakistan, Iran, China, Russia not far away. The United States was there having its troops on the ground, so there was a lot going on. There was a lot of violence. Major health needs, of course. We were running a hospital some 20 kilometers away from Kabul. But every week, I think, or every few days, I was surprised. I was very intrigued by something that I heard by the staff, something that I learned from them, something that I saw on the street. It's a fascinating country, as I said. But I had to choose one item of what I found so interesting culturally about this particular place, and I chose this statue. And it's not a particularly beautiful one, I have to admit, so you may wonder why I put it on there. But it's the story behind it that is interesting. So I saw this at some day, we were able to visit the Kabul Museum, which is probably the only museum in the country, which has some artifacts about the history of Afghanistan. And in that museum, I saw this statue, and it's actually a Buddha from the 3rd century. It said 3rd century after Christ, but I think it's supposed to be 3rd century before Christ, because it also has Greek clothes and Greek influences on a Buddha image from before, or let's say 3rd century before Christ. So I was wondering, of course, why this cross-section of cultures in this particular place, and it has to do with Alexander the Great. He had his campaign from Greek and Macedonia all the way into India. He was covering the territory. So that influence from Alexander the Great was there at the time that Buddhism also came to Afghanistan, long before Islam came. And this is a syncretism between these two cultures very early on. And just to tell you how many layers of civilization have crossed in this country, and how incredibly interesting place this is, but also for me, how much beauty and interesting elements you can find in a country with so much violence and so much poverty and so much suffering. So if you're open to it, you can see many beautiful things around the world. The second artifact is actually a short clip, if it works. If it doesn't work, it's not a major issue. I'll just tell the story. And I hope it's not too loud. So these are images from the funeral of Nelson Mandela. This is not from a football match. This is a funeral from Nelson Mandela. I was there when I lived in South Africa between 2012 and 2015. And it still brings shivers over my spine when I see it, actually. Not only find that super beautiful how they're celebrating his life at his funeral, and they're not weeping, but they're like celebrating his life. But also I know these songs because I have before that, I don't know the song itself, but I know the atmosphere and some of the songs that they were singing. I recognize the atmosphere because I had been on the streets with HIV activists, patients, with TB activist patients that were asking for access for treatments in order to survive in the years before that. And they were singing the same songs, the same anti-apartheid songs, because they told me it's the same struggle. They told me it's a luta continua, which is Portuguese for the struggle continues. It's the fight for a life in dignity. A life in dignity, whether it's political or to be able to live a life in dignity, having to live with their disease. And Mandela was also a symbol of that, because he himself was not only fighting apartheid, but afterwards he was also fighting the stigma of HIV, and he was on the forefront of his population, to get access to HIV treatments. And so I think this image really brings back again some of the atmosphere about activism, as Professor Schoors mentioned, about fighting for your right to be able to survive and to have a life in dignity, and which inspired me as well when I came back after 2015 back to Belgium, and I lived here, that I applied to become a representative for Médecins Sans Frontières for global access to medicines, vaccines, and diagnostics, which is a part of MSF, of Médecins Sans Frontières, the access campaign, which has been campaigning for 20 years for better global access, including for HIV treatments, TB treatments, but also for COVID-19 vaccines, for example. So that's a bit my story.
Thank you, Dimitri. Dr. Ayit Baron-Shetty.
Thank you, Dieter. As you can probably see, I don't easily follow rules. Sarah asked me to start with a culture object, and I thought about it for a moment, and I said, it's all about people. And those two people up there are people who dramatically altered my life, inspired me during my 7 decades. The first one was Sir Lawrence Bragg, who many of you might have known, created the theory of diffraction, which is at the basis of several scientific developments. And he helped me get into Cambridge. I probably wouldn't have gotten on my own. And one of the takeaways from him was, Ajit, if you can't explain something complex in a very simple fashion so that even the bus driver can understand, then it's clear you haven't understood it. So that was a terrific inspiration from these people. The other person was Paul Janssen. I think Jan also worked under him. And he was associated with this university and probably deserved the Nobel Prize for invention of medicine because he was most productive. And it was a pleasure to work under him. And 2 takeaways from him was he always met you and he said, what's new? So that clearly inspired innovation. If you didn't have anything new to talk about, you disappeared very quickly. And the second question was, get moving fast. And his slogan was, the patients are waiting. So these were the 2 people who made an inspirational effect on my life, and I thank them deeply. And so as I move on, I was thinking about the debate. I tried to set it in a global context, about pharmaceuticals, because I think it's good to situate pharmaceuticals in the global economic context. And if you look at the GDP, worldwide GDP, it's somewhere in the 90 to 100 trillion. And you look at healthcare costs, and healthcare costs is much more than pharmaceuticals. It's inpatient hospital costs, it's outpatient hospital costs, it's physician fees, it's administration, et cetera, and pharmaceuticals. And if healthcare costs run about 8 to 9% of the world GDP, pharmaceuticals run for about 2% of that. So about 2% of the world GDP is spent on pharmaceuticals. And I might add, some countries, and a few of our countries, are probably spending more on defense spending than on pharmaceuticals. So that puts the whole thing in context. So let me talk about my final slide, which is when I sat back and thought, how are medicines making a positive impact on society? And not all of it is due to pharmaceuticals. They are part of the reason. But if you look at life expectancy, patients and since the beginning of 1900, life expectancy has gone to more than double. And that's clearly a very large, apart from nutrition, standards of living, etc., a large part comes from medicines that have been discovered by various people. And also, if you think of improving the quality of life, like pain and suffering, a lot have been alleviated. The second thing is the economics. If you look at what the pharmaceutical industry does, it creates 5.5 to 6 million jobs across the globe, and if you use a multiplier effect, that's about probably 20 plus million jobs created by the industry, and huge amounts of R&D investment, probably about 250 billion. The third point where they make a difference is in healthcare systems. People only see the cost of pharmaceuticals, not the benefit. And if you look at several diseases, starting with even AIDS, as Madeleine knows, that's bringing down, AIDS was a death sentence. It's today a chronic disease. Bringing it into a chronic disease requires pharmaceuticals, and that can save several of the hospital costs that are created. And we can go on with many more examples of cardiac bypass surgery, etc. And the last is in society, and there are dramatic pictures I could show, but I can describe them to you. People who are suffering from rheumatoid arthritis, incapable of work, with some of the new biological antibodies, can be fully recovered, go back to work, 2 more years of productive life, more salary for their patients, and most important, they become productive members of society. So I rest my case that I do believe they are not the only reason, but they have a very positive effect on society.
Thank you, Ajit. And with these words, and now that we know the panel, we will start the debate or the discussion. And we try to structure the debate a little bit by having several topics. And we also asked our students to provide questions. And we selected some students to ask their question tonight. But unfortunately, the first student we selected to ask her question here could not be present because apparently at the faculty we give them too much work. And she had to prepare for some course. So the first student who was selected to have her question been asked then, and I will ask her question in her place, is Silke Verbeust. And Silke has a question on neglected tropical diseases. And she states that a diverse group of more than 20 conditions who mainly occur in tropical areas in the world, where they affect the lives of more than 1 billion people who live typically in impoverished communities, are, let's say, affected in their daily lives by these neglected diseases, often causing devastation in their social and economical situations. Now, the WHO has set targets, several goals related to these tropical diseases, and they claim, or they want to achieve by 2030, one of the objectives, which is eliminating at least one of these diseases from 100 countries. This, of course, will require a significant amount of research, of financial investments. And she states that since these diseases are for most people in the Western world far from their beds, and sometimes even considered to be non-existing, she asked the question how the WHO can motivate people, governments, pharmaceutical companies to be more aware of these diseases and to spend sufficient amounts in research and in finding new treatments, maybe also new medicines for the disease. So it's a debate. We all have invited you to ventilate, let's say, your ideas on the question. So it's not so much a question, it's more to open the debate.
Marlene and I were talking, I'll just kick it off, but she's the expert. You know, I find the word, and we've talked about it at the Institute of Tropical Medicine, it's really an outdated term, tropical diseases. I mean, you see, and Janssen has been at the forefront because several of the discoveries came from doctors who, like Madeleine, spent it out in the Congo and elsewhere, and they developed terrific anthelmintics like mebendazole, levamisole, in addition to other tropical medicines, which everybody thought was crazy. And then when Paul Janssen started working on AIDS, they said that's only for tropical areas. Little did people realize that with the change of, if we were becoming a global village, it was going to become a global disease. And number two, with climate change, they're talking about having potentially malaria in Sweden, as the global warming takes place. So I really believe tropical, in fact, I think it's more about public medicine, public hygiene, etc. And so I think when we talk about this, sure, there are certain neglected diseases where small sections of the population are addressed, but I think it needs to be a collective effort of pharmaceutical companies, government organizations, financial foundations like the Gates Foundation, who've got to put their efforts together to find solutions. But Margaret, Madeleine, you're much better qualified to talk about this than me.
I'm not an expert in the neglected tropical diseases, but I agree with you. I think we should call them neglected diseases or neglected public health, diseases or conditions. Because as you were saying, it's a global world with climate change. But the thing is, the fact that most of them, of this list of 20, mainly occur right now in Africa, Southeast Asia, in developing countries. There is very little in effort to do something about it. And it's not only on the NTDs, the neglected tropical diseases. For example, I can give an example from my own area, syphilis. It's not in that list, and there is a treatment for syphilis, very kind of cheap even, penicillin, but there is not one company or manufactured the dose to give to children, babies born from syphilis-positive mothers. We have already kind of tried for 30 years to have these small vials, but it doesn't bring money, so nobody is interested, and that's the neglected part of it. So I think the question is, what can WHO do about it? The good thing is that WHO brings it higher on the political agenda. If you don't talk about it, if you don't mention it, then nothing gets done. So the good thing is they bring it higher, they make a program of the NTDs and try to raise more interest, political leadership, of course also philanthropy and the pharma industry to sit together. And working together, we can come back to that later with HIV/AIDS, can really make a difference. So I believe in it, but it's a long way to go. And as long as you were saying, it's considered as something far away, think Ebola. Nobody was interested, only a few African countries. Then COVID came, it changed the whole thinking. So it's important that we have a global program around it.
Yeah, if I can add a little bit. So it's true that indeed it's a major problem that, I agree with the fact that the term is maybe not very well chosen, but in the end I think it's not a bad idea that there's a list of some of these neglected diseases, if we can call them that way, are being monitored, because it's true that there's a problem there. It's only 2% of all the global R&D investments that go to these diseases, which affect about 1.7 billion people worldwide. So it's a major problem for many people, but it's true that very little investment goes in there. And as Madeleine also briefly touched upon, the problem behind it is that, diseases that particularly affect poor people or very small communities in a rural community somewhere are not very interesting to develop any treatments on, because there's no commercial value behind it. So it also has to make us think about how we organize our research and development in order to meet some of these priorities and meet these targets. From our side, with Médecins Sans Frontières, Doctors Without Borders, together with the World Health Organization, we set up the Drugs for Neglected Disease initiative, which actually targets some of these NTDs and develops new treatments for them, and we've been successful in that. For example, for sleepless sickness in 2018, we brought a new oral treatment on the market, which is non-profit, so it's affordable, it's accessible, it's adapted to the places where they should be used. But yeah, there needs to be more funding to that, and that's for me, more a political issue, because I think there's little to be expected in terms of commercial interest.
Yeah, for me it should be just neglected diseases, and they are neglected simply because there's not enough profit in it. So for me it's a very simple economic problem. I understand that pharmaceutical companies are, of course, private companies, and that's going to drive, not completely, but to some extent, their research and development initiatives. So if you want to tackle these diseases, a lot of the effort will either have to come from research institutes or universities that develop it, or for some kind of directed investment by large government institutions that basically pre-finance the research and development to tackle these diseases in the way we did for COVID, where a lot of the research and development was pre-financed because we cared. So if you care as a world about these neglected diseases, because they're not profitable enough for the companies, it's a matter of government intervention. I think in a way it's a market failure.
Yeah. Well, you could indeed say that you cannot force private companies, not pharmaceutical companies, to go in any direction. But governments, there's also research, I hope, that is done at academic centers. And of course, research can be funded by governments into these academic centers. Is there a shortage of that? Should there be more? Should academic researchers be more encouraged to look into these in an active way or not?
Maybe I should not answer, but one of the things I worry about is that as universities, we also have become a little bit profit-driven.
Yeah.
And so at the moment
Indeed,
we do research, we already think about spin-offs, and that's fine. And if you make spin-offs, you think about cashing out, and that's also fine. But to some extent, it deviates money away in the same direction that pharmaceutical companies invest. And there needs to be some kind of a counterweight. Some of the money needs to go to things we did not expect a profitable spin-off, but we expect a profit for the world. And I think that's what governments are for. So we shouldn't forget that this is also important, and both need to exist, and they are potentially complementary. But now universities also more and more thinking about private financing flows, and then if you make a choice, well, do it about a disease that could bring money, but not necessarily help the most amount of people.
Yeah, we have professors who want to earn money also. That's the problem.
Yeah. We are also people. Yeah, of course. That's
Yeah, no, I think you really got to go on a funding campaign business, because what you said is very important. It's 1.7 billion. You can't just sneeze at it. I think you've got to go on a public funding campaign which addresses, the rich people of the world. There is a lot of individuals with much more money than for 10 generations. They should be willing to part with some of it for a good social cause. I think pharmaceutical companies, I know J&J has reserved some money for public health, etc., should be asked to sequester some of their money for these kind of neglected tropical diseases, or neglected diseases as we now call it. And it's equally important that governments also and academic institutions have a social purpose. There is a profit element involved, but I think there should be a social element also involved. So I think if you can take a piece of everyone's available resources and put it into a public fund, one can address this, and even probably stimulate research in some of these countries to look for solutions.
The model exists for emerging, we continue on the topic, but the model exists to some extent for emerging infectious diseases in CEPI, the Coalition for Emergency Preparedness for Innovation, which is developing vaccines for what was supposed to be, for example, for COVID-19.
CEPI.
CEPI. So a model exists where governments come together, donors come together, they all put money in a big pot and they say, this is the disease target that we're going to develop a product for. There's a model that can work, but we have to do it.
This brings me, in fact, to another example which is very closely related to what we are discussing. It's on tuberculosis. And here you can see an example of a university who's taking a lead in further trying to fight tuberculosis. But what was striking me, because I was reading about this, due to corona epidemic, we have seen that there is, again, a huge increase in tuberculosis cases and death. So I don't know, maybe just one small comment on this.
Tuberculosis has been a terrific product that's come up for multi-drug resistant TB, which came out of an individual called Koen Andries, who got recognized as one of the most innovative researchers in Europe. He was working in the Janssen labs. And the old drug was rifampicin with terrific side effects. And Ceturo, the product that Koen developed, has made a tremendous advance. But of course, there is an increase. And the question is, can Johnson & Johnson make it much more available, at an affordable price? Is a major question that should be answered, I think.
Yeah.
And there are also models for this. I remember in the early days, of HIV/AIDS, where we had no medication, no antiretrovirals at all, in the 80s, 90s, and research was going on here, and pharma was developing products. At that time, I was working in Kenya, and I was thinking, this will never happen, because here we cannot even have enough ferrous sulfate tablets to fight anemia in pregnant women, and it's so cheap, and we are not able, through the systems, how can we ever treat African patients with HIV/AIDS? It is just for the rich countries. And I'm happy to say that I was wrong. But what happened? Very expensive medication indeed, and UNAIDS, amongst others, Peter Piot, who was leading that, said we have to think differently and we have to bring everyone around the table. Pharma is not the enemy, but they make also money. So let's discuss price, cost, and volumes. So if we can have it, and the same kind is applicable for tuberculosis and so on, you can lower the cost of a drug if there are volumes. So if there are systems, countries, philanthropy, everyone around the table who guarantees that the drugs will be available and affordable, then pharma makes more drugs and also more benefits. So there are bundles available, it has been shown.
That's an interesting topic, I think, relating to the volume of drugs. Indeed, I think it's a very basic economic principle that volume comes normally with price decreases.
Mm-hmm.
Should,
yeah. Not always.
Should. We now see that in most Western countries, for a specific active compound, we not have 2, but sometimes 10 or even more different brand names, which actually are the same drugs. Would that be something that is maybe hampering that volume and price reduction, or is it good to have, it's always good to have some competition, but is it good to have so much competition?
A great question. You want to answer?
I want to come back to the TB point related to that, if you don't mind. And unless somebody wants to answer this question, because I'm not 100% sure of the question. No, I think, first I wanted to say it has been a deadly disease before COVID-19, or it has been the main killer disease around the world before COVID-19, but it dropped a little bit due to COVID-19 taking over, actually. So it has been a major problem, and we've been waiting for 50 years. And we're happy, of course, that Johnson & Johnson, Janssen Pharmaceutica developed bedaquiline. But indeed, the price remains a major issue, to be honest. And we have been strong in campaigning for Johnson & Johnson to drop the price significantly. The lowest price right now is around $45 per month per patient. The generic price is supposed to be between 7 and 17, so it's still quite a significant cut. And from what we understand from public publications that have been made, there was major public investments that went into the development of this drug. So there should be possibilities to further lower the price. And I agree with you, pharmaceutical companies, philanthropy, volumes can all drop the price, but let's not forget the factor of generic competition can really drive the price much further down. And then we come to monopolies and how monopolies, enable companies to set any price they want.
Patents.
Patents, patents are one form, but there are other forms, access to technology, access to data, etc. And that's a major factor in this case, of course, as well. That we would need to.
So I think this is an interesting intellectual question in a way. So on the one hand, it's clear you need patents, because developing these drugs is very risky. Then you need to get them accepted. You have all these tests that can take a long time. It can go wrong. So if there's no possibility to earn it back, nobody will do the investment. And so you need patents, because patents give you a temporary monopoly that allow you to increase the price, that allow you to earn back the investment. Great. But on the other hand, if the patent is too long or too extreme, profits are so high that you have a big cost in terms of human lives and health. So there's a trade-off about how long should a patent be, how strong should it be, and that's an infinite discussion. And that depends to some extent on the lobbying power of these pharmaceutical companies, but also depends as far as I'm concerned, on how bad the diseases are affecting societies. And I think if you have a case of very bad diseases that really rampage around the world, there's a good case for saying, okay, let's make the patent shorter, or let's pre-finance. Because if the government would to some extent pre-finance and de-risk the development, the case for patents becomes less strong because there's less to earn back. So if you really care about TBC, do the same as you did with Corona. Massively pre-finance companies to develop drugs, de-risk in terms of getting it acknowledged, and then you can say you have a shortened patent term, and then you can go very quickly generic, get it cheaper, and cure more people. But that's a societal choice. Companies will not do it on themselves.
But then the rich countries still buy all the vaccines to keep them for themselves.
Once you do generic, you could scale very quickly. Yeah. So in the
Yeah,
beginning, you're right.
is,
You're right.
Let me come back to one story which is familiar. I'm sure Marlene knows about it. You know, when AIDS suddenly hit, and South Africa was one of the countries which was extremely badly hit. And this is one, even though I worked in a multinational corporation, I think we have our faults, we have our flaws. I think if we had come together and said, let's provide, forgetting it's the patent issue, let's provide drugs at a very cheap price to South Africa, we could have done it. But you usually hear the argument, well, that dictator there, suddenly all the drugs that we sell to South Africa to be sold to South African patients will be sold in the West, and the money will be transferred by the dictator to a Swiss bank account.
Institutions.
Okay? And now let me come to the real story. So a friend of mine, 86-year-old, God bless his soul, but he also makes profit, Dr. Yusuf Hamid from a company called Cipla, which I'm sure Madeleine knows, saw this as a beautiful opportunity with the stupidity of the big multinationals. He rode into South Africa like a knight in shining white armor, and he said, I will provide one pill for $1 per day, which means $300+ per year, versus $12,000 that the pharmaceutical companies were charged. So it was a classic case of stupidity on the pharmaceutical companies, who could have come out smelling like heroes if they're joined together and provided it at an affordable price to the South African country, making sure that none of that product comes back into the West and be sold in the West.
Can I say
So
two more
where
things?
there's a will, there's a way. Sorry, Madeleine, you want to say something?
No, it's okay.
Yes, but maybe we can first, because this smoothly is connected to a question that one of our students want to ask. So I first would like to give him the floor, and then we can further discuss.
Thank you. Yes, so I have a bit of an introduction, but my question will follow. When we look back at the COVID health crisis, it strikes me that pharmaceutical companies received huge governmental support while they also continued to make high profits. When various parties called for the temporary suspension of patents on vaccines in order to increase the vaccination rate in other countries and to make full use of worldwide production capacity, this was met with resistance from the pharmaceutical companies. The argument used by the pharmaceutical industry was mainly that decreased profits would reduce the development of new drugs. However, the industry's reasoning that patents and higher prices are justifiable because of the high risk associated with research into new drugs does not hold in this case. The risk was absent because companies received a lot of support from governments, and orders for large quantities of vaccines were placed upfront, so large in fact that countries fought against each other to get their vaccines. So my question is, how can it be morally and financially justified for companies not to let go of the patents on COVID vaccines?
So who wants to give the first answer?
I'm happy to comment on it.
I agree.
Well, we were very strong on this particular issue on the intellectual property rights waiver. Just to be very, very clear as well, because this is often misunderstood. Not only on COVID-19 vaccines, also on diagnostics and treatments. And this is a very important point, because very often the pharmaceutical industry has said, if you're going to just waive intellectual property rights on vaccines, it's not going to help anybody. It may help, but it will take a long time, because there have been vaccines developed outside Europe, outside the United States. There have been vaccines developed in India, in China, in Cuba. There have been effective vaccines as well that were developed for COVID-19. They could have, some of these vaccines could have hit intellectual property rights barriers. In the end, they didn't, but it could have happened. That's one aspect of it. The second aspect of it is the treatments. They are a lot easier to produce. Some of these treatments, not all of them, but some of them are a lot easier to produce. And this was a main factor for us to say, this is very important to have it quickly, to have this waiver quite quickly. And not only on the aspect of patents, because intellectual property rights is often seen as patents, and it's a very important form of intellectual property rights, but there are others, and that's access to data, clinical data, and access to trade secrets that actually tell something about how to produce some of the medicines, treatments, and diagnostics. And it was these last two that are the most difficult to overcome. And this is why this was quite important for us to support this call by India and South Africa and actually 60 other countries for this intellectual property rights waiver, which unfortunately was never adopted, by the way.
Indeed, I think if we talk about intellectual property, it's not only patents. And patents expire,
exactly.
But trade secrets, you can
Never.
keep them forever, right?
Yeah.
Coca-Cola.
Mickey Mouse. 70 years, Mickey Mouse.
No, but if we think about the patent issue, I think here also, as you said, in the COVID vaccine situation, it was not just about the patents. It's also about other intellectual property that hampered sometimes. But in the end, I think having patents is not only in the pharmaceutical industry. Patents is quite broad. It's even not only in industry. It's also in academia, as you said. Also, academics try to get patents. Do we think, if you say, well, there's of course some issues with patents, should we then change it for all industry, for all partners, or specifically for the pharmaceutical industry, or specifically for certain treatments, or in specific disease settings? Or?
So I think it's a balance between profit and public health. And I love patents. I think patents, as I explained, serve a role, but in circumstances, it makes a lot of sense to waive them, I think. And that should depend on the balance between, so for example, COVID-19 is a worldwide massive threat with huge economic costs. So here, there's really good reasons to waive the patents. Imagine you have a very small disease that nobody wants to treat. That is not very profitable to start with, that we need a lot of government investment to develop something, then maybe it makes sense to have a little patent, that at least you can protect it. So I think it really depends on the case. So in general, doing away with patents, some people argue for that, and they say it would speed up innovation, but I also see costs. I see a cost to that in terms of risk, in terms of safety. You would have a lot of competition, but probably less security. So I think it's risky, but in some specific cases, I think it makes a lot of sense to waive patents or to waive patents for specific groups. So you could say, if you can stop parallel imports, as you were talking about, with South Africa re-import of vaccines, if you can make sure we can stop parallel imports, why not waive patents for certain countries that cannot pay these vaccines? Especially since in the end, if disease ramps in these countries, it will affect us too. So it's a smart investment, actually, in a way.
Yeah, on the same line, I had 2 points I want to make about the academia and universities. I think also there a lot of new design, new drugs or new diagnostics can be developed. But I think academia still has to do better in valorization of their own products. And number two, I think in adding also in the patent discussion values such as equity, accessibility, affordability, so that we have huge profits made on the one hand, and we need to develop the waiver system, or however we call it, better so that these inequities are addressed. Because that's the big thing.
Yeah, no. I want to handle this two ways. The first thing is patents, for example. I mean, I have a very simplistic approach. I mean, which invention has come out of the generic industry? Okay, so I think that answers the first question. So you do need some kind of incentives to be able to make profits. And then the point that you raised, Marlene, is how big should the profit be, you know?
Yeah, that's
and that's what you also raised, Koen. Yeah. You know, it's a very simple thing. When you put, I mean, I don't have to tell this class, you all know it. When you put it in a risk-free, you get a very low rate of return. When you put it in a high risk, you could probably go bust, or you get a high return. I mean, that's the basic law of, you know, what's happening around investment strategy. So I think you do need a return for the kind of risks you take, because everybody talks about the few pharmaceutical companies that are successful, and there are studies. You make excessive profits, 14% after taxes versus general industry 7%. That's all right, but nobody thinks about the millions of other companies that fall by the wayside, you know? So there's a hell of a lot of risk involved there as well. So I think, you know, you go back to the specific situations you were talking about, I think we've got to find solutions for those situations, which everybody has to be enlightened, but don't throw the baby out with the bathwater. You know, so, you know, the patents are important because they create a system of innovation. But if there are cases where, you know, health is a right and not a privilege, make sure that we can address that situation.
Could I respond?
First, relating to the fact that I think Kunyu correctly stated that for some settings, maybe longer patents are of value to encourage development, let's say, not only by pharmaceutical companies. The European Union has that system in place, actually, where they encourage, you have, besides, of course, the patents, you have market exclusivity for a certain indication, where the EU has set companies developing in orphan diseases, or then further on for pediatrics, that they get additional market exclusivity to.
That's a good idea.
Yeah, and that's, I think, one of the things that is in that direction. But Dimitri, sorry.
Yeah, I think there's quite a bit of misconceptions about the positive impact of intellectual property rights in pharmaceuticals. I'm not saying about intellectual property rights in general, but in pharmaceuticals there are some major issues. And the issues are, first of all, there's a problem with priority setting. Because of the profitability that the intellectual property rights system kind of encourages, a lot of the money, and we talked about it already, goes to the, you know, the disease areas which are more profitable rather than the ones that really need a treatment. Antibiotics is a clear case. There's very little profit to be made from new antibiotics because you're not supposed to use new antibiotics, you're supposed to keep them on the shelf. So that's one aspect, but you can also talk about tuberculosis, NTDs, etc. The second one is affordability. It doesn't serve the patients that the prices are sky high for almost every new treatment that enters the market. In addition to that, new treatments are not necessarily better. Prescrire every year publishes an overview of the products that have been approved. 50% of them have no added value. Those are approved medicines. 50% no added value, 20% maybe some, most of them, and then from time to time, a big improvement, 10% worse, actually more harmful than useful. So there's a major problem in the quality of the output of that system as well. And then the third point that I want to make is it doesn't always help innovation. And then we can come back to tuberculosis, for example, where we have several medicines on the market, but nobody was investing in how to use them. There was no treatment. There's no treatment regimen. And in the end, Médecins Sans Frontières, we ourselves have done clinical trials in order to get the right composition of the dosage between these different pills and how to use them in treatments. And that's because there's competition between these different players that do not collaborate. So it stifles, in a way, innovation as well. And there are possibilities to change the system for better health outcomes. Maybe we can come back to that at some point.
That's a task for universities, to do this kind of research. So
Could
there
be,
are options here to
Yeah, well,
do more research.
I think it's indeed also a problem. We know that there is quite some medication out there, which is already out there for a long time, for which we know that in certain indications they would serve very well, but indeed nobody wants to do the clinical study because they will have no or insufficient
one clear example we had with
protection.
COVID, right, where the steroids, very cheap steroids, turned out to be the most effective treatment, but we waited a long time to see that, too long probably. So, but on a very general level, I would argue, look, the private sector is probably the best in creating innovation. I think most people would agree to that, and I agree to that. But it's not sure that the private sector is the best in choosing the direction of innovation, because they are, of course, driven by profit. They will choose to innovate in sectors where they think they can earn money. But these are not necessarily the sectors where you have the highest health benefit. And that's why some way you need to direct the innovation. And that's where universities come in, public spending programs come in, CIPI comes in. That's why you need these kind of initiatives to direct the technological change. But one of the typical consequences of this problem is that there's probably too much investment in R&D in curative pharmaceuticals and probably too little in preventive. Because if you invest in things that prevent diseases, in terms of profit, it's self-defeating. Unless it's a very big worldwide disease. But if you want to prevent something that's not very small and it works, you will kill the disease. And that's profit-wise self-defeating. So that's not something.
How many people wear masks?
Exactly. How many people still wear masks? So there you need governments to develop this kind of programs. Taxpayers.
We have some vaccines that were able to almost eradicate certain infectious diseases, right?
Yes. Yeah. But they were often invented at universities, to be honest. Yes.
Time-wise, I think we should shift to the next topic.
Yes, the next topic we wanted to discuss is indeed a very broad topic on antibiotics and resistance. I just would like to say something personal. Last week I was in Malawi, and I was struck by the fact that there is a huge cholera epidemic ongoing. And as you can see on the slides, there were the daily updates, and it reminded me about COVID again. And if you see the number of deaths and so on, and this is a country without war, without conflicts, so I was really questioning how is this possible. And then I also asked my colleague there, do you have easy access to medicines? And I thought he would say, oh no, it's very difficult, I cannot buy anything. He told me, oh yes, of course, we can buy everything, all antibiotics, no problem, we don't need any doctor's prescription. So, yes, I would like, for me it was the first time I heard such things, so I would just like to have some comments on this, because, yes, if we then think about antibiotic resistance, these big outbreaks, so I would like to hear your...
Can I start with this one, yeah? I think that's very common in many African countries, not only in Africa, but surely there. And I think that the thing is, in the African countries, I know there is no public health system. Primary health care is not really very developed. So people always go to a specialist. They go to a dispensary or something, and there we give antibiotics. Because you have to give something strong, right? You cannot send a patient home saying, well, you live healthy and you do this and this and it. No. When you are a good doctor or a good nurse, you give a strong antibiotic or a strong drug. And then, very often, compliance is very poor. There is no kind of national guidelines, or very few, or nobody knows about them. It's not in the training systems. So what do people do? They go and buy 1 or 2 pills, or they buy 4, and then they share them with others, because we share everything, right? So that's one of the big causes of resistance. One wants to buy drugs, and they are everywhere. You can get them on the market, on the dukas, everywhere, but then you buy 1 or 2 pills, and the compliance is terrible. The fact is that there is not a system that is like, here we have our GPs, the family doctor, and then you can refer to a specialist. But that is not really developed in Africa. A lot of efforts have been done, but people go, if they have money, you go directly to a specialist. You get the worst treatment there is, but you pay a lot. If you don't have money, you buy a little bit here and there. So that's one of the reasons why we have so many problems. If one could introduce really, number one, primary health care, strengthen this, include this prevention and treatment in the curriculum of the medical doctors, the nurses, the healthcare providers, there would be a big change. And the pharma, maybe some of you will work in developing countries. In most of the pharmacies, you can buy everything without any prescription. And a friend tells you, you buy this, you go and you buy and you take and you drink. And so it's really chaotic. So policies, systems, control is really needed. Primary health care with prevention.
Marlene, out of interest, in these settings where you say you have maybe shortage in GPs, which is also occurring in some Western countries now, as I understood. But if you have a shortage in GPs, the people dispensing the drug, are those pharmacists, and would there be a value in better training them in not just to sell 2 or 3 or 4 pills? Or
Absolutely, absolutely. So we need, and we pharmacists, they play a very big role in the public health system because they dispense the drugs, they give also health education. It's not only doctors, the nurses are very important, the pharmacists, the allied health sciences, so they play a very big role in better training. But it's also money-making. You know, it's also a money-making business. So the little pharmacies, they try to sell whatever they can. And there is very little kind of responsibility, training. You just do your training and you try to make money.
it's always about money.
Let me tell a similar story of self-medication. Because I was in Bangalore in December, and on the flight from Doha to Bangalore, I got a terrible respiratory infection because I wasn't wearing my mask. And anyway, that's another story. So I went to my pharmacist and said, I need something for respiratory infection. He gave me azithromycin. 4 days, and I was, every night I was 5 times awake. So I said, the GP was next door to us, I know him. So I went to him and I said, this azithromycin is not working. Why are you taking this? Let me write you something stronger, amoxicillin. And boom, it went. So, you know, there is a lot of self-medication, GP. So I guess, you know, sometimes it works. But pharmacists can make mistakes, but GPs also make mistakes. So, you know, but I agree with you, Dieter. We should raise the level of education, even if it's self-dispensing. It's important.
And raise the level of diagnostic capacity, because it's a major problem as well, the diagnostic capacity to correctly diagnose that's a bacterial infection that can be treated with antibiotics and be specific in them. I just want to comment on the cholera point as well, that if I remember well, the only producer of cholera vaccines has actually, while there are 30 countries at the moment having an outbreak of cholera, the only producer of cholera vaccines has announced that it will stop its production of cholera vaccines. So it's a major problem with the World Health Organization now having to ration its doses. Why? Commercial interest is a problem.
Yes, prevention doesn't pay. That was my point in the previous thing, and that's really a problem. And that's why I need, in these cases, public policies. Like, for example, for cholera, you will not do it without it. Yeah.
Do you see ways that you, for example, now specific in this case, could encourage or maybe find another way of then producing the vaccine if the only producer in the world doesn't want to do it anymore?
For us, no. Vaccine production, I mean, I assume you know more about it, but it's very complex. It's not something that
no,
we...
it is, but
you make
could
noise. That's what we do. We will make noise, and we can campaign, we can speak out about the problem together with others, with the World Health Organization,
I think legally there would be a case to be made for if there is only one producer of a vaccine that is important for the health of the world, and the producer withdraws the production, I think by default it should also lose its patent.
I think it's actually off patent. I think it's actually off patent. This one is off patent.
Probably right. Yeah.
Sorry?
This is an off patent vaccine.
Oh, okay. So there's no generic producer in the world?
Well, it's a more complex discussion that there are no generic vaccines.
That's bizarre. That's something we need to solve. For sure. Why is that?
It's a technical issue.
It's a technical,
It's very complex.
Which vaccine is this?
The cholera vaccine.
Cholera.
Nobody does that. Why is that?
Well, actually, because generics is for small molecules.
Yeah. Okay.
And vaccines are not small molecules, so they don't fall under the legislation of generics. And they have to do comparative studies. And in order to compare, you need to originate your product. And in vaccines, it's very difficult to do a comparative study because, well, you need large populations to show that your vaccine works. Otherwise, you have to go into a setting where you intentionally.
No, but now you have a vaccine and a recipe that works.
Yeah, you can transfer it to someone else.
Why couldn't it be transferred to a generic?
Yeah, that's something else. Yeah, sure.
That's possible.
What you're talking about is compulsory license.
Yes, you should have a compulsory licensing in this case, yes. And that should be the legal default if the last producer stops, I would say.
But still, probably also this new entity will also want to make some profit, right?
SEPI. No, the new entity.
Of course.
Yeah.
But maybe less than the one that is giving up. Because we see, if you look at generic production, we see, and Ajit gave the example in South Africa, that the differences are huge sometimes in price. And that's simply because they want less profits. That's why they are generic producers. They're happy with less profits.
But I was actually wondering, and this may be a good panel to discuss, if as a company you have a production line going, if it's been going for years and the production works well,
how would you stop?
How could it be more profitable to stop than make a little bit of money, right?
Can I say something cynical?
Yes.
So if I would be total cynic, I would say if I stop now, I think the disease will spread a lot more, and then in the future, I will have a bigger market. That's very cynical, but it's maybe not so far from the truth, actually.
Really?
Otherwise would they do it?
That I don't buy.
No, of course I don't think. But what's the reason?
Because if you get discovered and it becomes transparent, you're pretty much finished.
Yes, but so why do they do it then? If you have, it's a good question. I find you have the investments are done, the innovation has been made, all the costs have been made. You just have to run the mill to make the vaccine, and then you decide to stop.
Well, if you're enlightened and there's a need for it, there's no need why you can't do it. You know, when you go back to the South African example, they could have certainly done it until somebody came and showed them you can do it, which was Cipla in this case. But my point is, the company which behaves like that, which simply stops because it's no longer interesting, I think is a very short-sighted company. I would hope Janssen & Johnson & Johnson is not like that. I don't know, Jan, maybe you have an opinion.
We should maybe shift to the next topic. We have a next question by, again, one of our students. Gilles de Baat, the floor is yours, I would say. Go ahead.
So my question is, should governments play a bigger role in regulating drug prices and the profit margins of the pharmaceutical industry to ensure affordable drugs, or would this rather lead to suppressing the innovation from the industry and ultimately harm patients in need of new treatments?
I think it's a great question, but very difficult to answer. You know, what is the right level of profit? You do need profit because you're investing very heavily in high-risk research. The second question is affordable medicines. You know, now there's no reason why a rich person can't pay. You know, they're buying all kinds of fancy cars, fancy jets. They can certainly pay for it. But you know, when you're coming into the line of affordability, the question is, what can we do to make it affordable to them? And the question, it's a tough question. It's not easy to answer because you can't have two segment markets. You can't have this product for a rich person and this person for a poorer person. So there's got to be some form, and in the US they're trying it with couponing, you know, so that if you think you're below a certain income level, I give you a coupon which gives you a discount when you buy the medicine. So there are ways to address it, and I think people have realized that we have to give an answer to your question. And so they're finding ways to have a high price to make a reasonable profit, and then for people who can't afford it, find heavy coupons to discount it for them.
We always talk about research and development cost, and that is there, but what is the percentage of research and development? I think there is a lot of money also spent in selling the product and
Sure.
advertisement.
Yep. We have at least most companies, and we definitely have very clear, this is marketing costs, selling costs, etc., which can run 10 to 15%. And research runs also 15 to 20% of net sales. You know, if the sales is 100, it runs at about a certain percentage of sales. The question is, do you need to spend so much on marketing and selling? Exactly. And to your question, can you reduce the price? I don't know. I have a joke about this. When Paul Janssen would say, it's the best drug in the world, everybody will come and buy it. I said, if people don't know about it, they won't come and buy it. So, you know, you have to spend some money in creating awareness. It was about a non-sedating antihistamine, one of the first in the world. Before, an antihistamine makes you sleepy, so you can't drive a car. You fall asleep when you're writing your projects. And so we came up with a non-sedating antihistamine which would not put you to sleep. And the question was, do we need to do any publicity? It's the best in the world. I said, you might be the best in the world, but if nobody knows about it, nobody will buy it. So you do need to spend on selling and creating awareness, but the question is how much? I don't know the answer.
So 2 weeks ago, there was an article published in the British Medical Journal, I don't know if anybody saw it, by Professor McGee, who is the president of the British Medical Association, and Els Torele, who is an academia here from Belgium working on access to medicines a lot as well. And it showed the evolution from, I think it was around the year 2000 until today. And the revenue that was generated by the major pharmaceutical companies went up from around $200 billion a year to $500 billion a year. And the R&D investments was pretty much a flat line the whole time. The median price went up from $1,400 per person per year for any approved new treatment to $150,000 per person per year in the United States. This was the United States. So it's a major increase of revenue that is created. And there is a little bit of an improvement in R&D cost, but it's quite small compared to the revenue that is being created. Lots of money is going into shareholder value as well, which is escaping society basically. So we would be more than happy to see that if there's a lot more revenue, that a lot more goes into R&D, but the reality is unfortunately not the case according to us.
Yeah.
And according to these independent studies as well. Now, what can we do about it? I think there are three elements that we can work with. One is transparency. We need to get more transparency on prices, the real prices that are being paid for medicines, prices, transparency on the R&D cost and the public investments. And then we need to leverage these public investments. Often the public, the governments, the academia, etc., are investing a lot. We need to attach some conditions to take control over whatever is the outcome of this research process, that we can set a ceiling to the price, that we say you need to share it with some producers in Africa and Asia, they can also have some possibilities to access. So those are some of the elements that we can play with. And then we have to think about the incentive system, how we can better model it for better outcomes. And there are options as well.
As an economist, I would like to add a big part of that specific problem is market power. If you have a lot of market power, if there's less and less really big pharmaceutical companies that compete with only a few, it's more easy to increase the prices. And this is a problem that we have in any sector. And in any sector we see that if there's few competitors, prices will go up and you're squeezed and revenues will go up. The usual solution to that is competition policy or legislation. Yeah. Think, for example, about mobile phones. There used to be a time that roaming was crazy expensive. And you call for another company who have data in the Netherlands and you're bankrupt, basically. And how did they change it? Just, it's a pen stroke law. The European Union just said, no, it has to be the same roaming cost everywhere. That's it. And that made now for all of us possible to easily do roaming everywhere or pay to another country. Same story. So with pharmaceuticals, I think there should be a pen stroke law that says, if in the European Union you introduce a medicine, you have to introduce it at all the at the same time. Maybe I was pulling something at the same time, or at least not too far ahead, because now what companies are doing is they're segmenting the markets. They're first opening a pharmaceutical in Germany or a rich country. It's logical, it's a big market, but at a high price. And then that's the reference price for the payback systems in all the other countries. And the reason they do that is not technical. The reason they do it, logically, I would do the same if I were a profit-seeking company. They do to maximize profits. But it makes us all pay more. And you could very easily solve this by saying, if you go on the European market, okay, and you have a medicine, it's a European market. So in the little documentation paper, it should be in all languages, and introduced in all countries at the same time within 6 months. And that would very quickly bring down I like profits, I do not like excess profits. So if the R&D doesn't go up, but revenues double, you can talk about excess profits. And these are never societally valuable. These you have to fight, and I think legislation would really be helpful there. And it takes just the courage of the European Union, like they tackled the banks with national payments, like they tackled the big phone companies, like they're tackling now the big tech companies with GDPR and with Google and Amazon. They should also do exactly the same for pharmaceutical companies.
I understood that what you're suggesting, Koen, is actually that something that many European countries don't want. I understood that many European countries think that they can better negotiate the price
Yes.
for a medicine than they would be able to do so if they would do it for the whole of Europe, which is, I think, a strange idea, but
Yes.
Yeah,
We also thought we
because-
could better negotiate the gas prices with Russia directly instead of at European level, and we saw how that went.
Dietrich, let me take this to another continent. The problem of acute pricing, first of all, I'm not sure about the percent, about the R&D spending. If we look at ours, it's a percentage, and the percentage is absolute dollars, it's the same. It's been going up, in fact. But in the US, it's been very acute. I know that medicines, which I buy here, it's double, triple the price. And the American public is beginning to make a big noise saying, are we financing the world's R&D? So the argument that's being used, and there might be some legitimacy in it, is the basic research is being done in the National Institutes of Health, in a lot of other academic institutions, a lot of universities, and that is being used by the pharmaceutical companies to do and discover new products. So there is a certain amount of basic research which has gone and paid for by the government, and should that not be a part of the pricing or the profits that pharmaceutical companies should have to pay when they come up with a blockbuster drug? So this is a big debate that's going on right now in the US about because it's really excessive, huh? It's unbelievable. Something that costs 20 euros here is $80 when I buy it.
So one of the things I've seen is that Biden, for example, had this law for diabetes, where he simply said, I'm going to slash the price because it's excessively profitable.
And WHO has made a list of essential medicine, right? So that list should be kind of guaranteed that this is affordable, accessible for everyone. So to answer your question, should there be regulatory frameworks? Yes. And a country where the regulatory frameworks are not very strong is the US. And then you have this venture capitalism.
On pricing, yeah.
Then you have this venture capitalism, like the story of this family who made the oxycodone, what's the name again?
Oxycodone, Purdue.
Yeah,
The Sackler family, they're on all the museums.
So they make millions, billions, all right? So many people are dying, it's kind of...
It's the addictive painkiller, is that the one?
Yeah.
Oh, yeah.
So
Oxycodone.
Oxycodone.
Yeah, Oxycontin.
So they made, I mean, nobody actually stopped them, actually court cases yet, but they made fortunes and people were dying because they needed more and more of these drugs. 500,000 Americans died and nothing happens. So then they came to court and they had to stop doing this. But regulatory frameworks are so important. I think here in Belgium we are...
And the medical profession, because a lot of that was happening in 4 states where a lot of the doctors were in the pay of...
exactly.
And they were getting commission. But anyway, that's a separate story.
But if I can give an example of a pen stroke change that I think can happen quite quickly. The research that I've done and that was published is on supplementary protection certificates. A very boring term, sounds very administrative, but it basically comes down to a patent term extension. So after the 20 years, a company can still be granted an additional up to 5 years of patent term. The research that I have done for some of the medicines shows that actually companies recoup their investments in 4 years in the basic patent term. But still, after the 20 years, they can still get an additional 5 years and they don't have to justify it. The cost of that is estimated in the Netherlands around 600 million euro per medicine. So it's huge. There's no need for this. There's absolutely no need for this. We can do a pen strike and we can take the system out according to us without major consequences.
You just have to do it. Resist the pressure and do it.
Well, not us. I don't have a pen that can do that.
The people we elect.
Yeah. We have a last question by one of our students, and Marlies van Damme. She's present in the room, but she didn't dare to ask her question. But maybe now she sees how friendly you all are. I would still like to give her a last option to ask the question herself. No? So I'm going to ask it for her then. She had a question on actually the publicity for medicines. She was asking if it's ethically justifiable that publicity is made for medicines, and she was also asking if in that publicity there is a sufficient conveyance of information that is, let's say, scientifically sufficiently correct to the patient. So what do we think? We have talked a little bit already about marketing, about publicity. What more do we have to say?
Well, you know, I said it before, you do, a lot of the GPs, information comes from the representatives from the pharmaceutical companies. That's studies galore, and we won't go into specific numbers, etc. The second point is misleading information. At least in the US, they're extremely tight. You know, you do get wrapped and you get fined. If you, for example, a product which is used for mycotic fungal diseases is very good for whatever reason for prostate cancer, and you start promoting it for prostate cancer, you can get into very serious trouble because it's not been approved by the regulatory authorities, the FDA. So you've got to be very strict guidelines as to how you promote it within the framework of what's approved by the FDA. So I think there are pretty strict guidelines on that. The question is there excessive publicity? And I think maybe there is. But, you know, what is the right level? I don't have an answer to that.
Well, I think in Europe, well, in Belgium I know because I'm in the commission who regulates the publicity for medicines. In Belgium, it's quite restricted to medicine that is non-prescription. So you can only make publicity for non-prescription medicines in Belgium. And every publicity is quite carefully looked at. And in the commission, we also have representatives of the patients and also like testaankoop, who is quite critical on these things. So it's quite well regulated. But I intentionally put a slide on there which contains a publicity for, and I'm not going to say a medicine, it's a product, Tasectan. There's of course also these things which are not really medicines like Tasectan, but which are sold to the public looking very much like a medicine. And because it's not a medicine, they escape all legislation, right? So there's also a risk, I think, in that. It's not just the publicity of medicines, it's the publicity for also other things that are used in healthcare that are making publicity. And Ayita, as you said, there's a publicity that is made to the broad public on television, but there's also marketing, of course, which goes to the treating physicians.
Correct.
Which is a totally different kind of publicity, of course. Maybe it's not even publicity, it's more like marketing. I think it's not always the same.
That's the bigger part in the pharmaceutical company, exactly what you said. It's the people that go to inform the doctors. In the US, OTC, like you said, is allowed, but if you do advertisements for prescription products, you've got to get the full leaflet, so it can become very expensive. Warnings, black boxes, everything. So the full leaflet of the medicine has to be in the newspaper. So it can be very expensive, so there's not that much. Similar to Europe, sorry.
The advertisement is a bit out of my field, but what I think would be very helpful is to have more head-to-head comparisons in clinical trials between products, that we really know standard which one works best, and I think that's the best publicity any company can get, actually. And unfortunately, it doesn't happen enough.
Yeah, it's indeed difficult. Yeah, for products that are already out there, it doesn't happen.
No. In COVID, it happened with the UK recovery trial, where they did comparison between different products, and I think that would be very helpful to have that also for vaccines and other products.
But again, it's something you shouldn't or couldn't expect from private companies.
No, not at all.
They're not going to do it. No. They shouldn't do it. I mean,
but
because then you wouldn't trust it. So there's room for an agency that does that.
Sometimes there is like investigator-driven trials who do that, but they're very limited. They're very limited, unfortunately.
And clinical trials are not cheap, you know that.
No, they're expensive.
But I think the advertising is even more for non-medical, not medicine, but for other products. And a lot of money is spent there. It's dermatologically proven, right, on television all the time. And in Africa, it's really a big business. Absolutely. So a lot of money is spent, but it's difficult to control because you can make a lot of, you can advertise Coca-Cola and all kind of food products. And so you can also advertise kind of vitamins. That's a little bit, but it's a big business. How to deal with it, I'm not very sure. It's good that around television programs, you know, that there is not too much of this marketing. So, but we need to do more there.
I think this has gotten worse because of internet.
Yeah.
Because it's now so easy to buy products on the internet, and many people think that Google is a doctor, right? And let alone ChatGPT in the future. So people that will not believe they're doctors, they will believe they have all kinds of diseases, and now they can easily order on some website somewhere the product, hopefully it is the product, and then this whole massive marketing expenditure starts to make more sense. Because also, if you search on Google, like belly ache and this, Google profiles you very quickly, and you will get the advertisements of these products you can buy in some company, and they will send it to you, and it will arrive in a package. So, to some extent, this is, I think, a consequence. The blossoming of this is a consequence of the fact that we have an internet economy. And I'm not sure how to deal with that, to be honest.
Maybe another pen strike we need. The Belgian law specifically speaks about publicity on radio and television. So any publicity on social media is non-regulated.
Okay.
Much more difficult.
Another signature law, right? That's a pen stroke law. That takes 5 minutes to add internet to that, and it's solved. Someone should do it.
I think we've consumed the time that was foreseen, but we don't want to leave our students without having a take-home message. So we hope that each of the panel members could have a short take-home message for our students. Maybe we can start with Ayit, because you actually have prepared a slide with a take-home message for our students.
Pretty straightforward. It's not rocket science. It's really pretty much covers what we all said, you know. At the end of the day, if we are talking about the new brave world of healthcare, it's not just the pharmaceutical companies, it's the academic institutions, it's the research institutions like the IB, it's like the government payers, it's the regulators, and it's the public that all have to play a role in defining this new brave world if we want the 3 A's that we used to call them. If you want access, affordable, and as we know from the pandemic, available, because it's not always available. And so, as Dr. Janssen would say, the patients are waiting. Thank you.
Thank you, Ajit. Marlene?
Maybe I translate this into an African proverb where they are saying it takes two to make a child, but a village to raise a child. And we are all part of the global village.
Yes.
So I think, and you can apply this to so many, it's not only the doctors or the pharma, or it's also the leaders, the community, the people. So it's kind of, this evening is very important, I think. We should have more than one to kind of grow that global thinking and making sure that all of us have a role to play and do play that role.
My takeaway would be all people are multifaceted. We all like to earn good money and make profits, but we all also care about public health. And all of us have this internal fight, I think. But you guys will decide the future. Many of you are the young guys, and you will be sitting here in some years' time making decisions in companies and governments. So if you have to make that evaluation, keep in mind, profit is great, public health is better.
Thank you. Dimitri.
So, yeah, I have two takeaway messages, a bit based on my own life experiences as well. The first one is embrace the uncertainty of your young life. The uncertainty that it brings allows you to do whatever, and not whatever you want, but to do a lot of different things, to explore, to travel, to meet people, and to do and try things, and, you know, fail as well at this, because it's really, you know, this is how you grow. The second one is, there's a lot of problems that are not solved in this world. You know, major challenges, from climate change to access to medicines to dealing with pandemics, etc. We don't have the solutions. We don't have all the answers. And as we've seen today, just talking among us, we already start to point at each other where we can find potential solutions. And there's a lot of potential for all of you to be making some of these changes that we need as well. And it's just, you know, a matter of doing the right research and having the right spirit to challenge what exists right now and to improve it. Even advertisement apparently needs some improvements. So there you go, there's possibilities there that you can grasp.
Okay, thanks a lot. So we came to the end of this debate, and I would really like to thank our panel. So thanks a lot to Dr. Ajit Shetty, and a round of applause for him.
Thank you.
Thanks a lot, Professor Marleen Temmerman. Professor Koen Schoors. En Dimitri Ennikel. Thanks to my colleague Dieter for the...
Thanks to my colleague Sarah.
Thanks for the whole FFW team who helped us to set up this meeting. And of course, thanks to all of you to be here this evening and to spend this time to think about the societal impact of your future jobs.
Thank you. Dank u wel.